So all of you are familiar with the neurology topics that Dr. Ryan covered. Some of the drugs that she covered are going to be kind of a review, so I'm glad that she kind of did that. And so I won't spend as much time on those, but hopefully for the next 90 minutes or so, we're going to talk about a lot of different psychiatric disorders, some that you may be very familiar with, some that you may have never seen, but hopefully I can try to guide you toward what you should focus on for the purposes of the exam. So my conflict of interest disclosures, learning objectives. So we're going to cover today major depression, bipolar disorder, schizophrenia, anxiety disorders, insomnia, and alcohol withdrawal dependence. I'm going to talk about the various therapeutic options, as well as just kind of recognition of some of the symptoms that you should be familiar with. We're also going to talk about specifically the drugs in terms of how to distinguish, because you'll notice for a lot of psychiatric conditions, many of the drugs have equivalent efficacy. They all work pretty much the same way with some slight subtle differences in pharmacology and MOAs, but really how we define them and how we use them is highly dependent upon they're just subtle differences between the drugs. And so that's what kind of makes pharmacotherapy of psych disorders a little challenging for those who don't see it every day. So hopefully I can kind of sway you, and I have a lot of tables in the chapter ranking the side effect profiles, and that's what you should focus on, because I think that's how we select the drugs as well. And then how to finally kind of formulate a therapeutic plan for some of these disorders. So the first disorder that we're going to talk about is major depression. This case is on page 242. So we have AZ, who's a 45-year-old woman with sleep apnea, hypertension, diabetes type 2, and chronic pain. She endorses the following symptoms: sad mood, poor appetite, where she's lost 15 pounds. She has poor concentrations, and she has feelings of hopelessness and worthlessness for the past 3 weeks. She has stopped going to her book club because of a lack of motivation to even get out of the house, and she frequently wakes up in the middle of the night due to her symptoms. She denies SIHI, which is suicidal ideation and homicidal ideation, so she doesn't have any thoughts about hurting herself or others. She denies the use of alcohol, tobacco, or illicit drugs, which is probably rare in psychiatry, but I'll just make this simple. We're getting to substance abuse in a minute. That's coming. She's currently taking hydrochlorothiazide, metformin, she's taking Vicodin, and aspirin. And so far, Vicodin is not a C2, so again, we're not going to get into that issue. You decide that AZ should receive a SSRI, selective serotonin reuptake inhibitor, to treat her depressive symptoms. So I'm just going to go over before I go to the first question. So we considered the DSM-4, technically DSM-4-TR. The DSM-5, for those of you who are interested, are coming out next month. But for now, we'll use the DSM-4 diagnostic criteria to really give us guideline as to how we should qualify someone to have a clinical depression or major depression or any of these psychiatric conditions. So according to DSM-4, major depression is defined by someone having a depressed mood or anhedonia, which is defined as loss of interest or pleasure in the things that you usually do find pleasure, and 4 or more target symptoms below for at least a duration of 2 weeks. So 2 weeks is really kind of the cutoff period that you need to look at. So it's not only the presence of symptoms, the number of symptoms, but also the duration of symptoms. I highlighted depressed mood or anhedonia because you have to have at least one of the 2 symptoms to be diagnostic. Even if you have 6 other symptoms, but you don't have depressed mood or anhedonia, at least according to DSM-4, you don't have major depression. There are 9 symptoms total, and you have to have 5 total out of the 9. So depressed mood or anhedonia has to be one of those. You can have weight change, which can be loss or gain. I would say most patients with depression have weight loss or decreased appetite. Sleep disturbance, you can have insomnia or hypersomnia. Again, most people have insomnia. Decreased energy, feelings of worthlessness or guilt. Decreased concentration, psychomotor agitation or retardation, and recurrent thoughts of death or suicide. What we also worry about with any psychiatric condition is that we want to make sure that it's not being caused by something else, including medical conditions and medications. And out of the medical conditions, I think the number one thing that we always do not ever want to forget to check is their thyroid function. Hyperthyroidism very closely mimics signs of depression, so we want to make sure that we check their thyroid panel whenever someone comes, especially into a unit. We want to rule that out first. But of course, other conditions can very closely resemble the symptoms of depression, as I've listed there. Some medical comorbidities also have a bidirectional effect or relationship with depression, like diabetes and cardiovascular conditions and MI, where they can either precede or be subsequent to depression. Medications, I've listed those in in two different categories, high probability versus low probability. A lot of people have a lot of different ideas about what causes the symptoms of depression or what can mimic symptoms of depression. Certainly we talk about any CNS depressants. So whenever you see a question that says, any CNS depressants, any of these are contributing to the symptoms of depression, I would say those are probably the highest offenders. As well as the interferons, of course, that's been very well documented. I list a beta blocker, propranolol, as a low probability, although I have to say, this is sometimes often used on exams. I tell students this, and I tell those who are taking other exams. For some reason, there's always been this thought that beta blockers in general cause symptoms of depression, and that's based on older studies that have really not been borne out in recent studies. Probably with the exception of propranolol, that because it is the one that penetrates the CNS barrier, that may have a more likelihood. But if I had to compare all these agents, I would say propranolol is not my number one choice of what's causing symptoms of depression. I would blame that on benzodiazepines, barbiturates, alcohol, and those. So patient case, question number 1, which SSRI would most likely interact with her current medications? Remember, she was on, let me just go back and remind you, that hydrochlorothiazide, metformin, hydrocodone, acetaminophen, and aspirin. So A, citalopram, B, fluvoxamine, C, paroxetine, D, sertraline, or blue, red, green, or yellow. If you can just... I don't see a C of anything. So B, I see some Bs, I see some yellows, Ds, I see Cs, paroxetine, okay. So the correct answer is paroxetine. So there's a table in your guide, a book on 244 about the different CYP enzymes. And this is another way, in addition to side effect profile, that we choose to select different medications. And just think that all antidepressants, are they inducers, inhibitors, or are they substrates? They're all substrates, all psychotropic agents. They all go through the liver, with the exception of probably a couple of agents that do not. But for the most part, they all go through the liver. But when you think of antidepressants, you should think of them as inhibitors of CYP enzymes. And specifically, there are some that are really high offenders. The ones that are 1A2, fluvoxamine, and possibly fluoxetine to a moderate sense. Not so much for 2C, but 2D6 is a big one because there's so many agents that are potent inhibitors of 2D6. And the ones we worry about are things like fluoxetine and paroxetine. And remember that this person was on hydrocodone and acetaminophen, and if you add those two together, obviously it will prevent the hydrocodone being metabolized to the active agent, so the person will not get any pain analgesia. So that's a very important, I think, drug interaction to remember. But 2D6, again, there are a lot of other drugs that are substrates for 2D6, and Paxil is notoriously known for inhibiting that enzyme. As well as 3A4, there's also the fluvoxamine and nifazodone, which we don't really use anymore, but certainly those can have potential. And then minimal drug interactions with venlafaxine, desvenlafaxine, and mirtazapine. Okay, so the next question is, which antidepressant would be most appropriate for her symptoms? Bupropion, fluoxetine, mirtazapine, or venlafaxine. So kind of remember her symptoms. She has some sleep problems, appetite problems. She has low energy, amotivation, anhedonia. I see some C's, mirtazapine. Great. Okay, so yes, that's the correct answer. So we'll go through that. So how do we select an antidepressant? As I alluded to earlier, obviously the person has to have major depression. There's been a lot of studies that say, antidepressants are just placebo. It may be the response rate is not that great compared to placebo. However, so we definitely do want to reserve antidepressants, and minor depression can be treated with things like psychotherapy. But when you start getting to moderate to severe depression, randomized controlled trials have shown, as well as effectiveness trials have shown, that psychotherapy plus medications provide a far better likelihood of remission than just psychotherapy alone or medications alone. So we definitely want to reserve medications for people who really need it. We also look at previous response or family response. I'll ask them, if most likely they usually have a family history of a mood disorder, and if, it's really strange to think that, just because your sister had responded to a certain agent like sertraline, that, there's a higher likelihood of that person also responding to the same medication. So that's also a good thing to ask. Severity and type of depression symptoms, I won't get into here, but there's some medications that are more likely to be effective for certain symptoms, like more activating or more sedating. We'll get into that in a few slides. But also atypical depression versus just regular clinical depression. So there's some evidence to show that certain medications are better. Patient preference, of course, just like Dr. Ryan was talking about, women may not want certain medications because of cosmetic effects. It's the same thing. So we always talk about, maybe a young teenager may not want medication like that would cause them weight gain, for example. Financial consideration, of course, side effect profile, risk of overdose. Certainly tricyclic antidepressants are definitely not preferred for people with suicidal ideation or risk of overdose because it can be very toxic. It doesn't take much to overdose on TCAs, and so that definitely don't want to give them a 30-day supply, for example, of a tricyclic medication. Comorbidities, of course, always play. If there's two things that we can treat with one medication, we'll choose that agent, as well as their possible age and ethnicity. So what are the adverse effects? And here there's a lot of different medications, and what I try to do is at least rank the side effects for at least as SSRIs to kind of get you familiar with what my thought process. So CNS effects, we like to rank them as the ones that are more likely to produce insomnia, we call activating, versus sedating. So we say that fluvoxamine, which is not really one for depression, it's more for OCD, but definitely fluvoxamine and paroxetine are more likely to cause sedation. So for people who have insomnia, this might be a good agent for them. Versus fluoxetine, it tends to be the most activating. We don't like to use the term stimulating in psychiatry because stimulants have a bad connotation in our field. So nobody wants to have a stimulant type of drug. So we say it's activating. Headaches and vivid dreams and nightmares are also very common. People say that it's not necessarily nightmares sometimes, but it's more just dreams are more vivid. They remember it more. GI side effects are also very common. That's probably the first thing that you see: nausea, vomiting, diarrhea, constipation. Paroxetine tends to have a little bit more potential for causing nausea, vomiting. Anticholinergics, again, paroxetine has a slight anticholinergic property that the other SSRIs do not have, and so it might be something that's not favorable for someone who should avoid anticholinergic agents. There's some other side effects because it affects platelet serotonin. For SSRIs, it may cause some bleeding and anemia. So we talk about that in patients who already have anticoagulants or antiplatelet agents. Sexual dysfunction, of course, is very common with SSRIs. Actually, this is a serotonergic effect. So any drug that affects serotonin can cause sexual dysfunction. So it's not just SSRIs. It can happen with TCAs. It can happen with MAOIs. It can happen with all the venlafaxine or duloxetines, even though people always associate with SSRIs. So I put figures there anywhere from 30 to 73%, but I would say it could be higher because of stimulation on the 5-HT2A receptor. The ones that tends to be the worst, at least, is fluoxetine, then followed by sertraline, citalopram, escitalopram. Paroxetine I would also include there as well. The type of sexual dysfunction is often described for men as delayed ejaculation or anorgasmia in women. Rarely it's the libido. Libido is more related to the symptoms of depression. So sometimes we talk a lot about differentiating that. QT prolongation, some of you may be aware of this already. The FDA warning came out about the risk of citalopram and the risk of QT prolongation at doses above 40 milligrams. So we definitely want to limit that to 40. It used to be the max dose was 60. But now the max dose for adults is 40. For elderly, it's actually 20, or anyone with a risk of QT prolongation. Withdrawal syndrome, I listed prostatine because we're talking about SSRIs mainly, but also venlafaxine. Anything that has a short half-life can induce withdrawal syndrome. Please keep in mind that withdrawal symptoms with SSRIs or antidepressants are not life-threatening. It's not like benzodiazepine withdrawal or alcohol withdrawal, but it is just uncomfortable. People say that they feel a little bit more nauseous, anxious, they can't sleep, they have these weird shooting pains in their extremities, their feet or their hands, like they're getting zapped, so that can occur. But it's not life-threatening. It just was uncomfortable for a few days. And then other idiosyncratic side effects that people often don't associate with SSRIs or antidepressants, but that definitely do happen, is sweating, bruxism, extrapyramidal symptoms can occur, SIDH. A lot of people, a lot of my colleagues in ICU, they call me about that side effect because they're like, hey, can antidepressants cause this? And actually it can. Weight gain, hyponatremia, and decreased bone mineral density. So it may be a risk factor in women who have osteopenia or osteoporosis. So patient case 3, so it's been 4 weeks since AZ's initial visit with you, and she's been treated with citalopram 20 milligrams a day. She still has sad mood, but her insomnia, concentration, and appetite have improved. But she still has feelings of helplessness and worthlessness, lack of motivation, and anhedonia. At this point, what is the best recommendation to optimize her therapy? A, continue at current dose of 20 milligrams per day. B, increase the current dose to 40 milligrams per day. C, add bupropion, 150 milligrams twice daily. And D, switch to a different SSRI. Okay, so I see a lot of B's. Great. Okay. So the dosing here for the SSRIs, you can see there, I try to put half-life, active metabolite, only really fluoxetine is the big culprit. But the dosing you can see, and this is just what I iterated for citalopram, the max dose now is 40. Because, and this is a common question we get about whether to increase, switch, discontinue, and do all these other manipulations. I think the key in that case was that patient was still improving. It was only 4 weeks. You still have a little bit of room to go in terms of the complete or maximum benefit of antidepressants, which are about 4 to 6 weeks. So she still was a little bit within that period of time before you see a full therapeutic effect. But also she was only on, and she has some definite improvement in many of her somatic symptoms, like her sleep, appetite, and those are what I also see as improving first. The feelings of helplessness, worthlessness, and guilt, all those motivation things, do tend to take a little bit longer, even beyond 6 weeks. So I wouldn't say this is necessarily a therapy failure, so that's why I would choose to increase the dose and then see. If she had absolutely no response, she went off for 4 weeks and nothing changed in her symptom profile, then I would say that we can switch to something else. And there's no point in adding a medication in that case either, because the first one didn't work. So why would you continue something that doesn't work? So what to do when patients don't respond? Again, you can wait and see. You can increase the dose. Sometimes we switch within class. There's no reason to there's no evidence to say that because someone has failed one SSRI, that they will fail all the other SSRIs or any other medications in that class. And actually, there's been reports of anywhere between 30 to 60% of people will actually respond to the second antidepressant, even if it's the same class. And you're like, why would that be the case? But that's exactly the conundrum that we always run into with all of our medications and with our patients, because we have no way of knowing which one is going to be the best for that patient. We're just almost kind of taking a leap of faith. We're kind of making a very educated guess, but we really don't know. And so if the person did fail citalopram, then I would just try something like maybe fluoxetine, maybe paroxetine or sertraline. You could switch to another class. You could have easily gone from an SSRI to maybe an SNRI. That's also another an opportunity. And then or add another antidepressant. So when you're adding agents, of course, now you're adding cost, you're adding another pill, you're adding another random side effect. So you need to think about that and say, what is my decision to add an antidepressant or even add a non-antidepressant, and is that going to give me a much better benefit than if I just left with one medication? So I try to do the clinical pearls at the end of each section just to summarize. So all antidepressants are equally efficacious. And our selection is really dependent upon a variety of different patient factors, as we've just seen in these cases, and drug-related factors. Their kinetics, their drug interactions, side effect profile, dosing. Sometimes, some agents are not dosed once a day. Remission, which means complete absence or at least almost no symptoms. That's our primary goal. We don't care if a patient responds in 4 to 6 weeks. We want to make sure that patient continues to respond and completely have no symptoms at the end of their therapeutic trial. Pharmacotherapy and psychotherapy always produce better outcomes. Onset of effect, the initial effect, may take up to 4 to 6 weeks. And a single episode of depression does require at least 7 to 12 months of continuous antidepressant treatment. So unfortunately, this is where we fail in that, a lot of patients will continue to get better after a month, and then they stop taking the medication. And unfortunately, them doing that, and this is the key point that I always tell my patients, is that just by you stopping a medication before you're fully treated dramatically increases your risk for having another episode of depression. So that's the big, take-home point that I want to make. So the same patient, 6 months later, she reports that although her depression symptoms have improved, she has trouble during intercourse, which is quite disturbing to her. You determine that she has anorgasmia caused by citalopram treatment. What is the most appropriate recommendation at this time? Discontinue the drug, add bupropion, switch to a different SSRI, or switch to mirtazapine. So this is 6 months of continuous treatment. Okay, I see. Okay. See a flurry of other things. Okay, so the answer is B, add bupropion to treat the orgasmia. Before I go on to bipolar, so I definitely don't want to discontinue because she has not been treated for the full course of the episode. I don't want to necessarily try a different SSRI because, as I said, sexual dysfunction is highly serotonergic. So just by most likely the person will have that same side effect with another SSRI. D, switch to mirtazapine. It is true, mirtazapine does not really have sexual dysfunction, but again, I'm kind of risking here. She's been good, responding very well to a drug. This is the point at which I would say choose a bupropion. And even 150, this SR formulation, 150 a day, has been quite effective in reducing the sexual dysfunction. Again, the other option is not to do anything. If she has said, I'm having trouble, but I don't really care, then I would not add. And a lot of patients actually will say that. It's like, you know what, me feeling better about my depression is so much better than me not be able to do other things. So it's a risk versus benefit. So you got to have that discussion. So, and if you have any questions, feel free. We have plenty of time. So, bipolar disorder. So this is page 251. We have JL as a 26-year-old man with bipolar disorder 1 who presents with delusions that the FBI is tracking his movements and that his thoughts are being recorded in a secret governmental database. He believes he has special powers to hide from the FBI by making himself invisible. He is hyperverbal and has not slept in the past 48 hours. He is placed on a 72-hour hold for control of his manic symptoms. He has a history of non-adherence to medications and is currently not taking any medications. JL's last hospitalization was 2 months ago when he has significant depressive symptoms and suicidal ideation. He has had 3 to 4 hospitalizations per year, and his medication trials include carbamazepine, olanzapine, and lamotrigine. It may have been helpful, he said, but uncertain because he wasn't really taking it very well. He's also recently received a diagnosis of hepatitis C. So number 5, which statement is most applicable regarding selecting JL's mood stabilizer at this time? Carbamazepine should be tried again because it's effective for preventing rehospitalization. Divalproex should be tried because it is good for maintenance treatment. Lithium should be tried because it can effectively treat the manic phase and prevent future episodes. And D, lamotrigine should be tried again because it is effective for bipolar maintenance. Great. I thought this was going to be the So C, lithium should be tried because it can effectively treat the manic phase and prevent future episodes. The other statements are not necessarily terribly wrong. I'll go through that, but definitely I think lithium is a better choice given his history. So manic episode, what does that mean for someone to be manic? It's a distinct period of abnormally and persistently elevated or expansive or irritable. I just want to highlight irritable because not everyone thinks manic patients are always happy. They're not. I've had patients who are very, very angry who are in a manic phase, lasting at least 1 week or any duration. Doesn't matter. If you're hospitalized, that automatically qualifies you as being manic. And you also have to have 3 or more of the following symptoms during a mood disturbance: inflated self-esteem or grandiosity, decreased need for sleep. So this is not insomnia like depression. They actually physically do not need to sleep. They don't feel the need to sleep. They're not tired. 3 is more talkative than usual, or pressure speech. You can't even get a word in inchwise. Like I can't interrupt them even to ask a question. They're speaking so fast. Flight of ideas or racing thoughts. That's, of course, their subjective feeling. Distractibility, increase in goal-directed activity, either socially, occupationally, sexually, or psychomotor agitation, or excessive involvement in pleasurable activities that have a negative consequence, like overspending, over-gambling, over being promiscuous, having multiple partners, for example. Okay? So this is my crude example of what a patient with bipolar may go through. They go from anywhere from mania to depression. Technically, there should be a period of euthymia in there, so this person would be considered a rapid cycler. They have their highs and they have their lows. They may be euthymic. There may be a year time in between those episodes. There could be 30 days. It doesn't really matter. For every patient, their cycle is very different. And so it's really hard to predict when the next hospitalization or next episode will be. I would say most patients with bipolar 1 spend most of their time in depressed phase, not manic. But when they are manic, they tend to be, that's what really leads to them being hospitalized or being arrested, being put in jail and those kind of things. So I try to summarize here. These are most mood stabilizers that we have available and their uses. Again, just be cautious that these are not necessarily all FDA approved indications, but these are based on recent guidelines. These are what we kind of use for mood stabilization. And you can see that lithium definitely has been used as a very effective for being useful for mania, depressive phase, and maintenance. Valproic acid, mania maintenance. Lamictal is interesting in that it's only indicated for maintenance, but it has shown some benefit for bipolar depression. And I just highlight that because we don't have a lot of agents that are effective for bipolar depression. We have everything that's effective for mania. All the agents we have are very good for mania, but we have very few agents that are actually effective for bipolar depression, and Lamictal is probably one of them. There are some antipsychotics that are also effective for bipolar depression, but that's very few. Carbamazepine, oxcarbazepine are definitely second line for treating mania or maintenance. And now we have all these antipsychotics that are, kind of being mixed into this, where we have a variety of different agents that are all effective for mania, but also some of them have been also indicated for maintenance. Just as a little asterisk there for quetiapine, maintenance is only for adjunct use, so you have to have a mood stabilizer on top. There is a theory that there's some people out there that think that antipsychotics alone, even though they're indicated for maintenance treatment, are not really going to be effective for maintenance treatment. We rarely, for example, you will probably rarely see a patient out there that is only on, aripiprazole alone for maintenance treatment of bipolar disorder. They'll usually be on another mood stabilizer like lithium, valproic acid, or Tegretol, something like that. And I don't know whether that's just our bias in the field or just our history with patients, but there's kind of that thought, even though I think technically they've all been approved for maintenance treatment. So some other things that you have to think about is the onset of effect, or how long it takes you to achieve efficacy. So lithium does take a little bit longer just because of the half-life. It does take about 1 to 2 weeks for you to eventually get titrated, draw labs, get a therapeutic level, and so forth. Valproic acid, you can achieve that very quickly. You can even load patients with valproic acid if they're in acute manic phase. Lamictal, we know that it does take a long time because of the dosing requirement. So it does take a long time to get to a state where we're comfortable with discharging them or getting them stable in an adequate dose. Carbamazepine, I think Dr. Ryan already probably mentioned this about autoinduction. So you do have to worry about fluctuating levels until a patient is stable. Oxcarbazepine, a little less time. Antipsychotics are probably the one that that's why I think in an acute setting, sometimes you'll see antipsychotics being used either oral or IM, the short-acting IMs, as appropriate control for mania. So when they're acutely agitated, come into the hospital, very unstable, you want to give them something that's quick and not just to give them a sedating agent like benzodiazepine. We may also do that too, but for something that would have efficacy against mania, antipsychotics definitely are very good for that. So technically we'll just do, antipsychotics first with a benzodiazepine, get them started on a mood stabilizer, and hopefully we can remove the antipsychotic once they're stable and lead them on an agent that has good therapeutic efficacy for maintenance treatment. Because I think our goal for bipolar disorder is not only control that acute phase of whether it's bipolar mania or depression, but we want to make sure that they don't come back to the hospital. We want to make sure they have prevention of future episodes. And that's the biggest challenge because we don't have a lot of great drugs for maintenance treatment. So which adverse effect, question number 6 is, which adverse effect would be of most concern and would require immediate evaluation if jail were prescribed lithium in this scenario? So A is hyperthyroidism, B is coarse tremor, C is severe acne, and D is weight gain. Great. So coarse tremor, and this is kind of a trick question. I think I see another answer there too, and I'll get into why I didn't decide that. But lithium is one of the rare drugs that we have in psychiatry that does not undergo hepatic metabolism. So when you think of lithium, renal, right? Excreted almost 100% unchanged by glomerular filtration. There are, unfortunately, a lot of disadvantages, and why, unfortunately, we're not seeing a lot of use of lithium, even though it's a very effective drug. Initial workup requires CBCs, electrolytes, renal function. We have to monitor serum levels, and there are slightly different serum levels that I listed here, depending upon if a patient is acutely manic or if you're just maintaining them for bipolar maintenance. So anywhere between 0.6 to 1.2 is kind of the therapeutic range that most people use for lithium. But if you're acutely treating an acute manic episode, you want to be a little higher in that range. So 0.8 to 1.2, I do a little lower, 0.6 to 1 for maintenance. Of course, there's other lab fluctuations like, our hospital, we go all the way to 1.5 as a therapeutic. So it depends. But, you can kind of see that you can get away with using a lower level for maintenance. This is one of the few drugs also where the levels actually predict your therapeutic efficacy. Not most drugs in psychiatry actually predict therapeutically anything, but lithium is one of those where you do need to reach this kind of a certain concentration. You do need to check for labs, other labs like thyroid function, urinalysis, possibly EKG. It's been recommended that people above 45 or people with cardiac conditions need to be monitored with an EKG. And then, of course, any childbearing women should probably not get lithium because of Epstein's anomaly. So here are some adverse effects, and the reason why I said, well, you just said severe acne, isn't that like rash or increased psoriasis where you said discontinue the drug? Acne is one thing, but I think rash is definitely something that we don't want to discontinue. But the severe acne, I qualify that, and if it's really, really bad and it's cosmetically unfavorable, I would say, okay, I could kind of argue that, you could probably warrant discontinuation of the drug. But what I really wanted to get at with that question is because as the levels rise, there are tremors, there are slight tremors that you see at a normal level. People will always complain of tremors when they're on lithium. It's just a very common side effect. But I do start to worry when their tremors tend to be getting coarser and coarser, more noticeable when you're sitting down with them, when they're, reaching for things and they can't, hold their cup and things. That's when I start getting really worried that they're getting toxic because that's the first thing that you see when the levels start rising. Of course, the other side effect is CNS toxicity. GI nausea, vomiting, diarrhea, of course, that's always seen the first thing. That's why we try to use a more extended release formulation for lithium. The citrate, the liquid, is very GI caustic. So it's not, unless you have to do that, we try not to use those. Polydipsia, hypothyroidism, excuse me. So hypothyroidism, very common. Hyperthyroidism, you may see it, but it's very rare. And even hypothyroidism, you do have to be concerned with that you may have to discontinue the drug. Polydipsia and polyuria is also very common, as well as, and then the whole renal effect. A lot of people used to worry that lithium was so nephrotoxic that you can't ever give lithium in patients who are elderly and so forth, and that actually is not true. The renal damage is actually kind of minor, and it's very controversial. So you want to obviously use the lower dose and lower concentrations, and of course trigenogenicity, where you want to avoid during first trimester because it does affect the development of tricuspid valve. So number 7, JL has been stable on lithium, 900 milligrams a day for 3 months. And during a clinic visit, he is confused and slurring his words, like I am now. His other medications include lisinopril, ibuprofen, atorvastatin, and zolpidem. Which is best to recommend immediately? A, discontinue lisinopril because it interacts with lithium. B, discontinue zolpidem because it may increase confusion. C, obtain a lithium level because JL may have supratherapeutic levels. D, discontinue ibuprofen because it interacts with lithium. Great. And the reason why I put this question here, this is actually a real scenario that we had. Patient comes into the ED all confused, slurring his words. He was combative, he was agitated, comes into the ED, nobody checks the lithium level. They finally get into the unit, and we realized there's never been any level. He was first seen in the clinic, then he was transferred to the ED because he was not doing well. No one had, by that time, it's been now, 18 hours, no one had checked the lithium level, and he was actually just had a lithium toxicity. Everyone was doing everything else, saying that, we need to increase his medications, we need to do this, we need to add a benzo, we need to do all these things. And the simple problem was we tried to check the lithium level, it's like 1.6. So I just want to highlight that's the immediate first thing you need to do whenever someone is on lithium and they're not acting their usual self. So situations to consider during lithium therapy, this is just looking at the drug interactions. There are a lot of drug interactions with lithium, and I think this kind of scares a lot of people from using lithium, unfortunately. We know the effect of diuretics, especially thiazides. Really the thiazides are what we have to worry about, where they increase lithium levels. NSAIDs also. Theophylline lowers lithium. ACE inhibitors also increase lithium. Neuromuscular blockers, neuroleptics, of course, they can either prolong the action or increase the risk of EPS. And carbamazepine increase CNS toxicity. But there are other situations where there are more pharmacodynamic interactions, where if you have, obviously, I already mentioned that lithium can cause hypothyroidism. During pregnancy, their actual GFR increases, so you need to actually, you actually need to increase the lithium level during pregnancy if a patient is going to be on it. Aging, of course, you want to, it can decrease GFR, so you may want to just be a little gingerly with the dose. Of course, it goes 100% almost in the renal, so you want to make sure that you adjust the dose accordingly. What I really want to talk about is a dehydration, because I think this is probably a common misconception or just misunderstanding about the dehydration. So I just wanted you to think about lithium being the same as sodium. They're both cations. So if you are dehydrated, your body automatically will try to conserve water, right? Conserve sodium. Unfortunately, it doesn't really know the difference between sodium and lithium. And so when you're dehydrated, your body will automatically retain sodium and retain lithium as well. So that's how you think about it. So hyponatremia states also result in the same thing, because you're trying to conserve sodium. If you're hyponatremic, you're going to conserve lithium. Okay? So that's a good exam question that always shows up, so you might want to just review that before the test. So the clinical pearls for bipolar is that selection of treatment depends highly on what phase you're in, whether it's acute mania, acute depression, or whether you're just in a maintenance phase. And mood stabilizers are not equally efficacious. Selection is highly dependent upon efficacy. So remember that table that I talked about uses. So which is it even effective for that state that a patient is in? And then drug-related factors, side effects, drug-drug interactions. We want to make sure the patients are euthymic, that they're not either depressed or manic. And we want to, of course, avoid hospitalizations. Onset of effect, generally within 1 to 2 weeks. But patients, unfortunately, may need lifelong treatment, unlike depression, where you may be able to recover completely and may not need lifelong treatment. Bipolar is probably one of those disorders that we generally treat for a lifetime. Very few people do well for a long period of time without having some medication on board. Okay. So schizophrenia, we just have to get through these three, and then it gets a little bit easier after that. So bear with me. So page 255, LM is a 25-year-old man recently given a diagnosis of schizophrenia, paranoid type. DSM-5, they're going to get rid of those types, paranoid types, these things. So it'll be a little easier. He often hears voices telling him that he is stupid and worthless and that he should just jump off his apartment building. His parents became very concerned over his isolated behavior and brought him to the hospital. He was given haloperidol in the psychiatry unit and now presents with neck stiffness and feelings of extreme restlessness. Until now, he has not taken medications because he felt that he can control his symptoms of it on his own with vitamins and Red Bull. Probably not the best thing to do. So number 8, which is the most appropriate treatment of LM symptoms at this time? A, benztropine, B, haloperidol, C, olanzapine, D, quetiapine. Yay, I see a blue. Okay, benztropine. Great. So we have conventional first generation or typical agents, whatever, all these nomenclature have been used interchangeably. They all kind of mean the same thing. It's the older drugs, right? And we have the newer drugs, which are atypical or novel or second generation. So the main difference between the first generation and second generations are that first generations primarily block just the D2 receptors pharmacologically. They also block a lot of other receptors, alpha-1, muscarinic, and histamine 1. And why that's important is because it leads to a bunch of side effects we'll talk about. But the other main, the difference because of the blockade of only D2 is that they block the positive symptoms of schizophrenia. And I don't have time to go over the positive and negative, but positive are things that we usually associate with schizophrenia. The voices, the delusions, the paranoia. Things that we all don't have, but people with schizophrenia have. They also, because they block D2 so tightly, they also block dopamine in a variety of other tracts that are controlled by dopamine in the brain. Specifically, nigrostriatal tract, which we know is involved in Parkinson's disease. So unfortunately, it leads to a lot of movement disorders or extrapyramidal symptoms. And they also block dopamine in the tuberoinfundibular tract, which controls prolactin, which is normally inhibited because we don't want to increase prolactin any other time except when we're breastfeeding. It does have a lot of untoward side effects or unnecessary side effects. The atypicals are a little bit more fancy in that they block not only D2, but they also block the 5-HT2 receptors. And they don't all block the alpha-1 muscarinic histamine the same way. They're all a little different, and that's what's going to be the most challenging. I think if you're not working with these drugs all the time, it's hard to know which side effects are associated with which one. But the benefit of having this 5-HT2 blockade is that they alleviate not only the positive symptoms, but they alleviate the negative symptoms of schizophrenia. The negative symptoms are things that we all have. Think of it this way: things that we have, but they don't have. Like, we have motivation, hopefully. You're all motivated to be here till 5 o'clock, thank you. So we all have motivation, we all have cognitive abilities, we all have energy level, we all have normal mood, we have, normal, expansive or, usual euthymia. But people with schizophrenia do not have any of those. And so they don't have good executive functioning, they don't have motivation, they have no energy, their affect is very flat, sometimes we call them, or blunted, where, whether they're sad or happy, I wouldn't know. They just have the same stone face in the room. So they don't have what we usually have. So kind of think about it that way. And they really don't affect the prolactin level, and they don't really affect the extrapyramidal symptoms because they don't bind tightly, or the 5-HT2 kind of allows the binding of D2 in the nigrostriatal and tuberoinfundibular tract not to be as tight. So that's the biggest advantage of second-generation antipsychotics. So in each class, whether first generation or second generation, the efficacy is kind of the same. So first generations, whether you pick haloperidol versus fluphenazine, or whether you pick thiothiazide or molindone, their efficacy is kind of the same. And whether in second generation, we have like 10 or 11 right now. So they're all the same. So we pick them based on side effect profile and drug interactions and so forth. Probably the exception of that rule is clozapine. It is one of the oldest second generations we have, but by far, clozapine is far superior in terms of efficacy. Unfortunately, we know the reasons why we don't use it very often because of the blood dyscrasias, but definitely we reserve it for treatment-resistant schizophrenia. So here's a table of all the first generations, and I've categorized them as potencies. And what you should know about the first generations are that the potencies drive the side effects. The high potency, I'll start with high potency because it's easier to remember. High potencies are haloperidol, fluphenazine, thiothiazide. Sometimes it's categorized as mid, but here I'll just say it's high potency. So these agents are highly bound to D2 receptors. Remember, the first generations only bind to D2, so they're highly bound to D2 receptors. They have the highest risk of causing EPS. So high potency, high EPS, high binding to D2. Low potencies are the opposite. They don't bind as tightly to D2, lower risk of EPS relatively within the first generation class, lower binding. Okay? But what do low potencies have, unfortunately? While they don't have the EPS risk, they have a higher likelihood of causing all the other receptor antagonism side effects. Histamine 1 blockade, so sedation, antimuscarinic effects, alpha adrenergic blockade. So they'll have orthostasis, they'll have sedation, they'll have all the antimuscarinic effects. So that's how you should remember. The mid are they kind of differ. But generally you always get tested on, the high potency versus low potency. That's what you should remember. Unfortunately, there is no good rule, and I wish there was a really great mnemonic to remember all of the different side effect profiles of second-generation antipsychotics. I don't. And so I don't know what's the best way to remember, but so clozapine is kind of the unusual duck. The clozapine and olanzapine, they all sound the same. They have similar side effects. Clozapine, because they're really efficacious, they're reserved for treatment-resistant, but they also have the most number of side effects. If you have to guess, if there's a side effect that you don't remember, if you have to guess and clozapine's there, I would probably choose clozapine. And then olanzapine, to a lesser extent, but very similar to clozapine. Risperidone, I call it the most typical of the atypical agents. It has the most potential to cause things like extrapyramidal symptoms, the movement disorders, the hyperprolactinemia. It binds more tightly to the D2 receptors, even though it's a second-generation antipsychotic, so I consider that to be more typical of the atypicals. Quetiapine is kind of in the middle somewhere. And then ziprasidone, I remember it for the QT prolongation. Aripiprazole is one of the newer ones where it's very metabolic weight neutral. Paliperidone, just remember it's metabolite of risperidone, so any of the side effects are going to be very similar to risperidone. Acenapine, alloperidone, lorazepam. I'm sorry, there's no really good rule. They're the newer three antipsychotics. Just going to have to review them. But I'll try to highlight some of these things. So extrapyramidal symptoms, just to review, typical. The high potencies are more likely to cause EPS. The atypicals, again, I put risperidone, paliperidone there as the worst offenders for extrapyramidal symptoms. I also put lorazepam because it has also been shown to cause a little bit more akathisia. Clozapine and olanzapine are kind of in the middle, along with quetiapine and all the others. I put asterisk there for risperidone and olanzapine because they're dose-related. So the higher dose you go, the more likely you are to get extrapyramidal symptoms. And again, this is due to the blockade in the nigrostriatal tract. Okay. There are three types of EPS that you should be familiar with: dystonia, akathisia, and Parkinsonism. Dystonia is any involuntary muscle contraction involving the neck, trunk, and other muscles, which is what this patient had. Akathisia is subjective. You may not notice it when you're looking at a patient if they have akathisia. You can clearly see dystonia, but you can't sometimes not see akathisia. It's a feeling of, some people have described it as crawling out of your skin. It's not necessarily bugs, because that's like LSD, but it's like crawling out of your skin. They feel very, very uncomfortable. They can't sit still. Sometimes they're squirming in their seats. They're wiggling their toes inside their shoes. They're kind of they're shifting in their seat. They look uncomfortable sometimes, and you don't know exactly what it is. When you ask them, they say, I feel really uncomfortable. I can't sit down. I can't sit still. Parkinsonism is, you just learned in the last hour about just, again, the tremors, rigidity. They look exactly like a person with a Parkinson's disease, but they don't have Parkinson's. It's mainly just an effect of their it is also difficult to elicit. Sometimes you see a mild shuffling of their gait, when you walk. I always have patients walk in front of me when I go to the rooms, and I kind of just look to see how they're walking, because sometimes they're kind of, stoop posture, kind of the shuffling and they have kind of, decreased swinging of their arms. You can kind of see that a little bit, because it's not very noticeable. It's not obvious like dystonia and akathisia. So treatment, of course, because the mechanism is that you're blocking the dopamine receptors, you want to give something that will alleviate that dopamine blockade. So the best way to do that is anticholinergics, because dopamine and acetylcholine have an opposing mechanism of action. So anticholinergics will actually treat all three dystonias. So if you have to guess, choose an anticholinergic, whether you choose benztropine, whether you use trihexyphenidyl, or you use a diphenhydramine even, that will reverse it. There are some other agents here that I just slight differences in how we treat maybe the akathisia. Sometimes beta blockers, propranolol will help with akathisia. Parkinsonism also, sometimes people will say you can use amantadine. I would say, though, the treatment of choice is always going to be the anticholinergic agent. Okay. So number 9, you and the psychiatric team decide to recommend risperidone for LM, what is the most likely reason for this selection, for choosing risperidone? Risperidone has less risk of causing EPS than haloperidol. B, risperidone is available in long-acting injection for increasing adherence. C, is risperidone is effective for decreasing LM's negative symptoms. Or D, risperidone can be dosed once daily after titration to a target dose. What is the most likely reason for choosing risperidone in this patient? I know all those, you're like, well, those are all good, but there's one answer that I think that's kind of explains great. It's B. Risperidone is available in a long-acting injection formulation. Because this person has history of non-adherence, you want to think about something that you can graduate to a long-acting for this patient. Yes, it is true that risperidone, has a less risk of causing EPS than haloperidol, but if I had to pick an antipsychotic in the second-generation class, I probably would not have chosen risperidone. It is effective for decreasing negative symptoms, because all second generations can do that. So again, doesn't really highlight the use of risperidone. And actually all antipsychotics, with the exception of, actually that's not true. I mean, most antipsychotics can be dosed once daily after you titrate to target dose. So that's not really an advantage of risperidone. So what is Consta? It was the first long-acting atypical antipsychotics. There are 2 others, Invega Sustenna, which is paliperidone Sustenna, and the newest one that was recently approved is aripiprazole, Abilify Maintena. Yeah. So Risperdal Consta is a delayed-release injection using it's just microspheres that are slowly released in the muscle. And the main release, what you have to remember about Risperdal Consta is that there is actually no sustainable or adequate level of the drug until 3 weeks. So there's the release of the drug occurs at 3 weeks and maintained for 4 to 6 weeks. So this is a biweekly injection. So every 2 weeks you have to get an injection. Paliperidone and Maintena are both once monthly. Okay? So clearly they got smart and they go, oh wow, we'll do a little bit better from the Risperdal Consta. So dose is 25 milligrams every 2 weeks. There is a 12.5 all the way up to 50, but most people start on 25. And dose adjustment should not be made more frequently than every 4 weeks, technically. Because of this delayed release, you have to have an oral medication on board until that 3 weeks. So you have to have the oral risperidone until at least 3 weeks, if not later. let's say a person decides a person is really severe, and we know that they're going to need higher dose of that than 37.5, 50. I'm still going to keep a little bit more of the oral risperidone on board. Okay? So which adverse effect of risperidone would be of most concern in LM? Sedation, anticholinergic effects, EPS, or QT prolongation? I just talked about this. So EPS, great. Okay. So again, this table I think may help you to study in terms of differentiating the different agents. So you can clearly see that clozapine is on top of the list, and they have the most number of 4s for anticholinergic, sedation, and orthostasis. What it does not have, is important to remember, is EPS. Clozapine actually can treat long-term movement disorders, and because it does not, the activity at the D2 receptor is so that it doesn't necessarily bind tightly as other agents. Risperidone, as I've just mentioned, as I mentioned, has a higher risk of causing EPS. It also can be somewhat sedating, and it does definitely cause orthostasis. Olanzapine, again, very close to clozapine, and you can see kind of going down the list there. Acenapine also is one of the newer agents, but it does have a lot of different side effects, including sedation, orthostasis, so just be aware of those. So 1 year later, LM is no longer responding to risperidone, and you decide to switch to another medication. He is only interested in oral medications. It's like, I'm not getting an injection, so just give me a pill. So which one of the following agents is most appropriate at this time? So I don't know, he's already tried haloperidol, which is not going to be good for him. Risperidone, he didn't really respond to. So next, clozapine, fluphenazine, olanzapine, or quetiapine. See a lot of blues. Okay, and some Ds. Okay. So the correct answer is quetiapine, and I do want to say what? So clozapine is definitely reserved for treatment refractory. And yes, technically, if the definition of treatment refractory, we can argue that's another 2-hour presentation, but, people do say that, okay, technically if you fail like 2 or 3 agents that you consider treatment refractory in real life and practice, we exhaust all antipsychotics before we go to clozapine, unfortunately, which is why the rate of clozapine use in hospitals is so much lower than what I would like to see, like 1%. Technically, about 10% of patients should be on clozapine, but that's here nor there. So I didn't choose clozapine because I don't think that just failing risperidone alone that qualifies him for getting clozapine. Fluphenazine is the first generation, so I wouldn't go back to that one because it didn't respond well to haloperidol. Olanzapine and quetiapine are my 2 choices, and the reason why I chose quetiapine versus olanzapine is something that's discussed in your chapter about metabolic syndrome, because I don't have slides on those. So this man's 25. He's probably going to be on medications for the next 30, 40 years. The risk of metabolic syndrome for olanzapine is very high, similar to clozapine. Higher risk of weight gain, higher risk of diabetes, higher risk of hyperlipidemia, and other cardiovascular conditions. Definitely, I think that unfortunately, olanzapine is a great antipsychotic in terms of efficacy. People do agree with that. However, it has now been relegated to kind of a second, third choice because of the high risk of metabolic syndrome. Quetiapine has a more moderate effect, and it does also have a less likelihood of causing EPS. So that's why I chose quetiapine. So it's kind of a more difficult question, I think, but I definitely want you to know that the metabolic syndrome risk associated with antipsychotics. Okay. So schizophrenia, in summary, all antipsychotics are equally efficacious except clozapine. Second-generation antipsychotics have better negative symptom control and less EPS. Selection is dependent upon a multiple, again, patient and drug-related factors. And remission may never be achieved, unfortunately. Schizophrenia is one of those illnesses that tends to just decline over time. There's really, people do not really recover. You're kind of delaying the symptoms. It's kind of like dementia, Alzheimer's disease. But really our primary goal is to control the symptoms as best as we can and prevent hospitalization while minimizing these side effects. When I talked about the weight gain, we're not talking 10 pounds. We're talking 50 to 60 or 70 or 100 pounds of weight gain. So imagine if someone comes in, their normal weight when they're 25, and you see them, 20 years later, they look like a different person. And I've seen that. I've seen those patients, and even within 6 months, a year, 2 years, they look dramatically different than when I've first seen them. So it's really unfortunate that they start developing diabetes because they can't control their dietary factors. They have to be on medications, and they also die about 25 years earlier than people without schizophrenia due to the cardiovascular conditions. Positive and negative symptoms and functional outcomes and cognitive impairment are key target areas for treatment. We want to definitely avoid hospitalizations. Onset of effect, 4 to 6 weeks, if not later. And then most patients also require lifelong treatment. Very few patients, despite what you see in movies, very few patients are ever off medications for schizophrenia. Okay. 30 minutes to go. How are we doing? Okay. All right. It gets a little easier now. Okay. So anxiety conditions, page 265. This is our CP is a recent Iraq War veteran who has been treated. Well, I guess not so recent. Okay, this is old, obviously. So Iraq War veteran who has been treated successfully with paroxetine for his MDD for the past 3 weeks. He presents to the clinic with nightmares, feeling on edge all the time. That's what he says, and flashbacks of his time in the war. He's evaluated and given a diagnosis of PTSD. He has no history of substance dependence and has no significant medical history. Very unrealistic, right? How many PTSD patients, if you've seen PTSD patients, how many of them do not have substance abuse history? Very few. Number 12, which recommendation is most appropriate at this time? Continue paroxetine because it treats both PTSD and major depression. B, discontinue paroxetine and initiate sertraline, which treats both PTSD and major depression. C is continue paroxetine and add lorazepam for the anxiety symptoms. Or D, discontinue paroxetine and start buspirone for the anxiety symptoms. I see green. Come on. Oh. Guess. I promise I can't really see who you are, so. Oh, nobody is responding. So the answer is A, continue paroxetine because it treats both PTSD and major depression. So we'll go through this. So before we get to PTSD, this is a good way to memorize the anxiety conditions. Everyone says, a lot of people say, well, he has anxiety, and his anxiety condition. And my next question is, what kind of anxiety conditions? There are 6. So anxiety is not a really clinical term. When you talk in psychiatry, we are very, very specific about what anxiety they have. No one can just have anxiety. So, patient who is often labeled as a worrywart, what kind of anxiety is that? If you've looked ahead in your book, this is a generalized anxiety disorder. People who just worry about inconsequential things. People who worry about everyday life things. Not specific traumas or not specific events or things, but this is just a general worry. Patient who spends 2 hours every day making sure her towels are neatly folded. OCD, everyone can recognize OCD. But I do want to warn you that it's not always about doing things. This is actually a patient that I had. She was in the hospital and she spent like 4 hours a day folding her towels over and over again. But it can just be obsessions. So they don't actually have to do anything. They don't have to necessarily wash their hands or go and check the lights or whatever. People always think that's OCD, but it could be just recurrent obsessional thoughts. I had a patient who who had these obsessions. She would never do it, but she had an obsession that she was going to throw her infant baby out the window. Those are her obsessions. She would never do it, and she never did anything else, but those are just her obsessional thoughts. Patient who startles easily and complains of nightmares about her time in combat. PTSD, right? Patient who has moments where she feels like she's dying and afraid to drive. Panic disorder, somebody said. Oh, I forgot one. Okay. Patient who's afraid of snakes and can't go to the zoo. Social phobia. So there's another disorder that's kind of labeled with a social phobia, which is social anxiety disorder. People who are afraid to eat in public or be in public, they're kind of the shy people. We consider them the shy, they were shy as a child maybe. They got worse and worse as they grew up. They're afraid to be in public. They can't mingle people, and they can't they can't go to work because they're so afraid of being around people where escape is impossible. So that's social anxiety condition, which is kind of a spectrum of social phobia, okay? Or specific phobia. So we treat everything with medications, or we can, not very well, but we do, except for the specific phobia. So if you're afraid of snakes and you can't go to the zoo, we just say, probably avoid the zoo. But if you're a physician and you're afraid of blood, that may require treatment. So it kind of depends. So specific phobia is not necessarily always done with medications, and very rarely we treat with medications. And cognitive behavioral therapy or avoidance therapy, all those things have to be done. But for the other conditions where pharmacotherapy is possible, here are the ones. And I listed the anxiety conditions on the left and the FDA-approved agents on the right. And you can see this patient with PTSD, the two agents that are approved are paroxetine and sertraline. And so the reason why, well, the patient already has major depression. So if the patient is responding well to the paroxetine for her MDD, I would just continue for PTSD. I may need to do some dose adjustment, either increase the dose or whatever, but definitely there's no point in discontinuing paroxetine if it's going to treat both the MDD and the PTSD. And here, so the best way to remember, I think, is to, identify what the disorder is and which ones have the most efficacy for that anxiety conditions. I would say if you have to guess, paroxetine would be a good one to guess because it's effective for all anxiety conditions. So that's a good one to know. And then sertraline is the next one. The one that I'll talk about, some of the agents that are kind of the odd ducks in here, like buspirone. We'll get to that. Okay, right here. So the CPE has been adherent to the medication you recommended earlier, but he still feels very irritable and has been aggressive at times at work toward others. Which adjunctive medication is most appropriate in this patient? Buspirone, clonazepam, divalproex, and lithium. Sorry, I don't want to mislead you, but it's not the slide that I was thinking of. Okay. So which adjunctive medication? There's some, okay. So actually, this is divalproex. Okay. So these are things that you would add on top of the antidepressant for any of these anxiety conditions. And I would say among all the anxiety conditions, PTSD is one that we use a lot of things adjunctively, possibly because they have so many different spectrums of symptoms within their anxiety condition. And so a lot of people with PTSD have these unremitting symptoms like nightmares. They are just very angry. They're very hostile toward their family members, and they can't just be around people. And they're very aggressive sometimes. Sometimes they are in anger management classes. And what we've found is that mood stabilizers are very effective for treating those symptoms, like lithium, carbamazepine, valproic acid, mood swings. People just say they're just not a good, fun people to be around. So sometimes we have to add some of these medications. We can use propranolol for countering their hyperarousal. Don't ever go up to a patient with PTSD, go behind them and, scream really loud or, touch them from the back because they will jump, 50 feet because they're trained to be on high alert all the time. And so unfortunately they can't tone that hyperarousal when they're in civilian areas. So propranolol sometimes is used to counteract that, as well as prazosin has been highly studied and very effective for nightmares, just as an add-on. So keep in mind, all these are add-ons. You would never do this as monotherapy. Nifazodone has been indicated for PTSD, but we don't use it because of the liver toxicity. And then trazodone, of course, is used heavily for sleep. Antipsychotics are really not good for core symptoms of PTSD, which is kind of the nightmares, the avoidance, the hyperarousal symptoms. But they are effective sometimes if they're having nightmares that are so vivid and they're constant, they're chronic, they're seeing, dead bodies while they're awake and they can't get rid of them. Sometimes we'll use that because it almost seems like a spectrum of psychosis because it's so unremitting, and we will use antipsychotics as adjunctively. Benzodiazepines, I have to say, I know there's a temptation to use benzos for anxiety conditions, and there's a huge debate about whether to use benzos and when not to use benzos. But I think for the most part, we agree that benzos, especially for people like, disorders like PTSD, and where comorbid substance dependence is very, very high, we generally do not like to use benzos in those patients because you can never get them off. There's a higher risk for overdose because people will take a benzo, drink some alcohol, take a sleeper, do all these other things, which is very dangerous, obviously. And then they also have major depression, high suicide risk, and so forth. So generally, we like to avoid benzodiazepines in anxiety. So number 14, after 8 months of treatment, CP is not responding to the medication you recommended. Having heard a lot about buspirone, he wonders whether this medication might be helpful for his conditions. Which is the most accurate statement for this patient? So A, buspirone is maybe helpful for the nightmares. B, buspirone may work as quickly as 3 days. C, buspirone is convenient because of its once daily dosing. And D, buspirone does not have much dependence potential. What is the most accurate statement? Great. So D. So buspirone, 5-HT1A partial agonist. It is not, one thing to remember about buspirone is that yes, it is used for anxiety, but it is not a benzodiazepine. And because sometimes it's often, compared to such, I don't know why, but it has no significant sedation, no cognitive impairment, motor impairment, or respiratory depression. So technically very safe. Some of the side effects I listed there, but generally very well tolerated. People do not discontinue buspirone because of side effects. However, another thing to note is that it has only been approved for generalized anxiety condition. It is not really effective or used for other anxiety conditions. The other disadvantage is that it takes a long time to work. It is a serotonergic drug. So it does take at least 2 weeks for the onset of effect. And this is where people kind of get into the business of doing benzodiazepines immediately while the buspirone takes time to have an effect. Unfortunately, what happens when you give someone a benzodiazepine? They don't ever stop. This is my main reason for not starting a benzo in the first place. Because you get into this, weird dichotomy with people, and they're like, well, it's so effective. Why wouldn't I want it? I'm like, well, there's a lot of other reasons for why I don't want you to take benzodiazepines. So I think just don't even go there. I think that's my little spiel. It does not have any dependence or withdrawal or abuse potential, so it might be ideal for those patients who have a history of substance dependence. And that's probably one main benefit. The dosing is unfortunately TID. Not very convenient either. I think off to the side, I think buspirone is generally not well liked by people, providers or prescribers, because of kind of the lackluster efficacy. Even though you think that it's going to be great and it looks great, unfortunately, clinically, we just don't see a robust effect as we do with the SSRIs or even benzodiazepines. So that's the only thing I want to say about buspirone. So the next question is, CP returns to the clinic and states that his depressive anxiety symptoms have much improved. However, he is concerned that his girlfriend, who has OCD, is not doing well in her treatment with lorazepam. If you were also treating the girlfriend, which one of the following is the most appropriate medication you would initiate? Clomipramine, amitriptyline, imipramine, or nortriptyline? I think I alluded to this earlier, is A, clomipramine. So just going back to that table, if you look at OCD, I had to throw in another anxiety condition here somewhere. So OCD, the first lines are among the SSRIs, fluoxetine, paroxetine, sertraline, but also fluvoxamine, which we don't talk about with depression. It's only indicated for OCD. The reason why it's only indicated, well, not the only reason why, but it is only indicated for OCD. It's also the most serotonergic SSRI that we have. And it seems like that serotonergic activity or that affinity to that receptor is really needed to treat the OCD. The reason why clomipramine is also very effective is because it is the most serotonergic out of all the TCAs that we have. So just to remember, serotonergic, clomipramine, fluvoxamine are the two kind of the first lines along with the other SSRIs that I mentioned for OCD. Okay. So insomnia, page 268. CD is a 38-year-old kindergarten teacher who presents to the clinic today with noticeable dark circles under her eyes. She has difficulty with sleep, mainly with staying asleep. It takes her about 20 minutes to fall asleep, which is pretty good. But after about 2 hours, she wakes up and cannot fall asleep again for several hours. This pattern has taken a toll on her job, and she feels tired all the time. She once took diphenhydramine for sleep, but had to miss work because of extreme drowsiness in the morning. She wonders whether there are any other medications that she can take. Her other medical problems include hypothyroidism, where she takes levothyroxine, 125 micrograms at bedtime, her hypertension, hydrochlorothiazide, 25 milligrams in the morning, chronic back pain, ibuprofen, 800 milligrams 3 times a day, and MDD, citalopram, 20 milligrams in the morning. Question number 16, which agent is the most likely contributing to CD's insomnia? Citalopram, hydrochlorothiazide, ibuprofen, or levothyroxine? Great. Yes, levothyroxine, never take it at bedtime, right? So I list here because the most likely for people's insomnia usually have some etiology. Primary insomnia, and that's called, older terminology with secondary insomnia, or there's other terminologies now. But primary insomnia, where there is absolutely no attributable factor or etiology or substances that are causing the insomnia, is very rare. Very few people have no identifiable etiology for why they're not sleeping well. Most people, 90% and above, have some other cause, mainly with medications and medical or psychiatric conditions. People with psychiatric conditions are notoriously, they do not sleep well. It's not uncommon for my patients to come in and say, I've never slept well. I haven't slept well in 30 years. That's not uncommon for them to say, because it is true. So medications, you really need to rule out the ones that are the most activating, like fluoxetine, bupropion, thyroid supplements that we just mentioned. Any CNS stimulants, decongestants, the other drugs here, as well as substance abuse, substances, any stimulating products like caffeine, stimulant medication like methylphenidate, nicotine, or amphetamines. Alcohol here, alcohol withdrawal, as well as long-term chronic alcohol can produce insomnia, as well as any CNS depressant withdrawal. So if you're withdrawing from a benzodiazepine, you're withdrawing on barbiturates or any other sedating property, then you will most likely have insomnia. So number 17, which medication used for insomnia is most appropriate to recommend for this patient? A, azopiclone, B, trazodone, C, temazepam, D, zaloplan. So remember, she had that mid-nocturnal awakening. So B, trazodone, or other, nobody? A, C, okay. The answer is actually zaloplan. The way to type or classify insomnia, we generally treat only the chronic, any symptoms that are greater than 4 weeks. The transient and short term really can be situational. It can be life circumstances. You had a loved one and passed away, or any environmental stressors like you flew to Asia and you have now jet lag or some other kind of contributing factor that really doesn't last very long. What we worry about using pharmacotherapy is for people who had 4 weeks or greater time of difficulty with sleep, where most commonly the causes are psychiatric illnesses, behavioral causes, medical causes, and so forth. And the sedative hypnotics are generally differentiated by pharmacokinetic parameters, how long they last, what the duration of effect as well as onset of effect, adverse effects, drug interactions, abuse potential, and of course cost. And here's a table that might be helpful for you to review, is that I've listed the ones that are the benzodiazepines as well as non-benzodiazepine agents that are really used for sedative hypnotic purposes, the ones that are used to help people to sleep. And of course, the reasons for not using benzos for sedative hypnotic purposes I've already alluded to many times, but they are still indicated and they're still available. Zolpidem, Zaloplan, azopiclone, or Ramelteon are the ones that are generally used, and that those are ones that are approved for sleep, as well as the ones that are kind of endorsed by sleep guidelines. Zolpidem and azopiclone, they have a longer half-life and they last a little longer, meaning that they're able to maintain people asleep, but they also have a higher likelihood of causing drowsiness in the morning, the morning grogginess. The Zaloplan is the one that is very short in duration, where you can actually repeat the dose. If you have at least 4 hours left in your sleep, you can actually take another dose in the middle of the night. So this person may not need to take a dose when she falls asleep because she has no problem with that. But during the times that she does wake up in the middle of the night and she still can't go back to bed, that's when I would recommend her to take the Zalopon. And she also doesn't have a risk of having daytime sedation or hangover effect in the morning. So that's why I chose Zalopon. Okay. Which adverse effects should CD be most concerned about when using Zolpidem? Or you could also say, what side effects should we definitely educate patients about when using any of these Z type of drugs? Orthostasis, disorientation, abnormal behaviors while asleep, and seizures at high doses of the drug. And everyone knows this because there's a huge med watch on it, and everyone has to get a med guide when they're provided this medication. So FDA issued a black box warning for all insomnia agents. They clump these two together, I don't know why, but angioedema as well as complex sleep behaviors, so CSBs, are what we categorize all of these odd things: walking, eating, having sex while asleep. And you laugh, but I've had patients who've endorsed these things, and I didn't believe it, but one of my patients actually, he said that his neighbors saw him walking outside of his neighborhood and going to people's different houses in the middle of the night. And he wasn't living in a very nice neighborhood, like a gang kind of ridden. And so he's like, I'm really concerned about my safety. And I said, yes, I am too. And so I said, lock your keys, somewhere where you can't get them or something, or, make sure you lock your doors and just do some precautions. Because he lived by himself, it's a little bit harder. But if you obviously have a spouse, I tell the spouse to hide their car keys, hide things that, and be kind of more vigilant about what they're doing in the middle of the night. So the incidence is hard to know. The data just came from when they measured levels of the drug, after 8 hours after taking a standard dose. And what they found was that even lower levels of plasma concentrations, actually it can produce a motor impairment where they're feeling like, because people were driving their cars and they didn't even remember that they were driving. They had no recollection, until they got in an accident or they got somewhere safely somehow, and they have no recollection how they got into the car, started driving, and got to where they were. And the risk factors actually are women. Women actually are unable to get rid of the drug as fast as men. So gender definitely is a factor. But things like people taking too much of the dose, not quite, taking just the 10 milligrams of the Zolpidem. People also combining with alcohol. People taking the drug too late. For example, they need to get up at 6 o'clock in the morning and they were taking it at midnight. It's not appropriate. So all those things can help, can drive some of the occurrence of CSBs. So substance abuse, we're going to get out of right on time. So substance abuse, alcoholism, it's on page 273. So Elam is a 50-year-old man with a 25-year history of alcohol dependence who was found unconscious after his last drinking binge. He was at first admitted to the medical unit for alcohol withdrawal symptoms before being transferred to the substance dependence unit. His last drink was 6 hours ago, and fluids haven't started. His history includes 3 alcohol withdrawal seizures in the past, an episode of delirium tremens, or DTs. He also has significant hepatitis, and liver function tests show AST, ALT values were elevated. So number 19, which symptom are you most likely to observe in the medical unit, given this history? Alcohol craving, delirium tremens, increased heart rate, and seizures. C blues, CB, D. Okay. All right. The answer is increased heart rate. Sorry. No? So before we get into timeline, I want to talk about just the management of alcohol withdrawal and dependence. So first of all, anyone who comes in, obviously, for alcohol withdrawal or suspected alcohol withdrawal is to get a tox screen, and that's just a standard of practice, especially in psychiatry. We just, whenever it comes into the unit, we get to run a tox screen, or even in the ED, hopefully someone ran a tox screen. We check for everything, of course, including alcohol. Check their renal and liver function test, folate, thiamine, B12, because oftentimes people who are chronically drinking are making up their calories with alcohol and not food. And so people are highly malnutrition, and this is how they get into trouble with some of the complications of alcoholism. And electrolytes. We always check also other things like thiamine, mag, vitamins, fluids. Of course, the other way to manage is to benzodiazepines, because I always say benzodiazepines are just alcohol in a pill. They work exactly the same. They work on the benzodiazepine receptor, they're inhibitory, they have a CNS depressant effect, and so when you're managing alcohol withdrawal with a benzodiazepine, you're just giving them alcohol. We don't really give alcohol as therapeutic treatment anymore, so we have to give the next best thing, which is benzodiazepine. That's what stops them from going into full withdrawal from the alcohol. Anti-epileptics, people have used anticonvulsants for seizures associated with alcohol withdrawal. Not really necessary. I think benzodiazepines alone are perfectly appropriate, and they're not generally, there's a lot of other side effects as you learn about anticonvulsants. And then hallucinations, we do use some antipsychotics sometimes along with benzodiazepines, but of course antipsychotics themselves, they lower the seizure threshold. So you need to be very concerned or cautious about using antipsychotics in a patient who may have alcohol-induced seizures. So this is what the question was related to, which is the stages of alcohol withdrawal and the onset in relation to the last drink that they've had. And of course, all these can maybe blur a little bit, but this is generally the guideline that we use. Is anywhere from 0 to 8 hours. You see the mild, the first symptoms are the vital signs, the tremors, nervousness, tachycardia, the nausea. Just people just don't feel well. Then it graduates to more of the really bad tremors, hyperactivity, tachycardia, insomnia, nightmares, illusions, alcohol craving is when this starts to kick in. And then when it gets into up to 2 days, they have more severe symptoms, but also this is when seizures are more likely to occur. So it's very important that we monitor alcohol withdrawal, even not just in the first 24 hours, because they can happen even 2 days, as early as 2 days, even up to 3 to 4 days. And then finally, delirium tremens is really what we worry about in the late phase, and that's why, I don't recommend people getting discharged too soon, because we can miss some of the DTs that happen really late or delayed phase. And of course, other things can happen as well as agitation, tremor, all these other vital sign labilities. So which agent is best for alcohol withdrawal symptoms in this patient for intramuscular administration? So chlorodiazepam epoxide, clonazepam, diazepam, and lorazepam. So D, lorazepam. And this is a table also from your book. And yes, diazepam, of course, also, I should check there, it's also available IV. But diazepam IM is really not, has a very erratic absorption in the IM. It can be given IV, of course, but in the psych unit, we don't have any IV lines, so we have to resort to IM administration. But lorazepam is preferred because it's very predictable, very good absorption IM, so we tend to use lorazepam. Diazepam and chlorodiazepam epoxide, they have a much longer half-life, and so this is something that you might want to consider in patients who are very brittle. They are very unstable in terms of the alcohol withdrawal. They're likely to having breakthrough seizures, breakthrough alcohol withdrawal symptoms, versus lorazepam might be better for people who have more liver dysfunctions or maybe who are elderly, have other drugs that may interact, but to the cytochrome P450. So number 21, before administering fluids with glucose, which agent is most important to administer? Folate, MVI, B12, or thiamine? And everyone, okay, it's a good question to end with. So Warneke encephalopathy, of course, is something that we all want to prevent as a manifestation of alcohol withdrawal. Due to severe thiamine deficiency and malnutrition, there's about a 10 to 20% mortality associated with this. And it is a medical emergency. We definitely want to watch out for this, is something we definitely look out for. It can have a variable course, abruptly onset or delayed, with gradual symptoms. People definitely complain about being more confused. They can't remember things, that you told them, or they sometimes will have paralysis of the ocular muscles. They have polyneuropathy, hypothermia, hypotension can occur. And what we want to avoid is progression of this Warneke to Korsakoff psychosis, where about 80% of the cases does progress, where they will have frank psychosis, seeing, there's a pink elephant in the room, they'll see things in the walls, they'll see just illusions in the room or in front of them. Or amnesia, they'll have absolutely no memory of what happened right before the admissions, or when you tell them things over days, they won't remember those, or frank hallucinations. So this is something, and unfortunately, in some patients, this doesn't go away all immediately, or it doesn't go away completely. So this definitely, we want to make sure that patients don't progress to this. Okay. So number 22 is which medication is best to use in LM for alcohol dependence? A, acamprosate, B, diazepam, C, disulfiram, or D, naltrexone. So this is for the chronic management of his alcohol abuse. So the answer is acamprosate. And what you have to remember about these three drugs, so diazepam was in there just as a red herring. It's not really used for alcohol dependence, the chronic management of alcohol abuse or alcohol dependence. But the three agents, disulfiram, naltrexone, and acamprosate are the only agents we have that has really been shown to, prevent people from drinking. Not necessarily craving, but people from drinking. Disulfiram it's an old drug. It's basically aversive behavior, but it doesn't really do anything for your craving. People stop drinking when they're on disulfiram because they feel bad, But I have had many alcoholics who can actually drink while on disulfiram. So that is not really an effective measure. So they're so tolerant that it doesn't matter how bad they feel. They will drink on disulfiram. But naltrexone and acamprosate are the two newer agents that have really been shown to decrease the craving, or physiologically your body will demand less of alcohol. Compared to the two agents, naltrexone undergoes liver, while the picture is there, versus acamprosate undergoes renal clearance. So acamprosate was, the newest agent around, Camprol. This would be so effective or so beneficial for all our patients with alcoholism who have liver dysfunction. Unfortunately, in a trial, they compared naltrexone, acamprosate, and then a combination. What they actually found was naltrexone was much better in terms of reducing craving and producing remission or preventing relapse of alcohol abuse compared to acamprosate. So in terms of efficacy, there is a slight advantage with naltrexone. But of course, you do have to worry about people being also on concomitant opiate therapy while on naltrexone. You can't start obviously in those patients because you'll induce a full-on opiate withdrawal. So they do work a little differently, opiate versus a GABA, the glutamate and GABA systems for acamprosate. Dosing for acamprosate is kind of easy to remember, 666 milligrams, PO/TID, versus naltrexone 50 milligrams. So if you see an odd number, think Camprol. But if you have any questions, I know I always get questions by email, sometime right before the exam, like, when's the exam? October 2nd or something? I get a question like August, 31st, about something in my slides. So if you do want to email me, I will be happy to respond back to you. But thank you. Sorry for the microphone and speaker issues, but thank you very much.